Thank you very much, Michelle. So I am Charlotte, as introduced. I'm a clinical academic in respiratory and intensive care medicine in the UK, and I'm not what would be normally considered part of the public health community in a sort of a global sense. I am someone who practices at the bedside as well as running a research group looking at how we develop mechanistic insights for therapies that can make patients better. So I'm coming to this problem from a very clinical perspective rather than necessarily a global public health one. So with the question that I was set kindly by the organisers of this meeting, the place I wanted to start with it is, what is the everyday work of healthcare? And I'm not sure that health systems across the world necessarily are clear about what they think it is. And what do I mean by that? What I mean is healthcare actually the prevention, diagnosis and treatment of disease, which is very much an ill health or disease-focused system? Is that what we're looking at? Or is it actually about supporting individuals and populations to attain a state of complete physical, mental and social well-being, and not merely the absence of disease, as the WHO has suggested? And I'm not sure necessarily that individual health systems across the world have reconciled them to whether they're providing a disease system or a health system. And so thinking about our everyday work, we probably need to do a bit more work on thinking about what our actual purpose is and what we're trying to attain. There's been a lot of talk about the depoliticisation of healthcare and that perhaps we need to think about building for the future healthcare that is separate and not interfered by politics. But I want to highlight that I think healthcare, however we deliver it and however we define it, is not delivered in a vacuum. It is not a discrete entity in and of itself. Health and well-being depends on education, it depends on housing, employment, political and social environment in which we are delivering that, because actually our politicians and our social society determine the budgets, they determine our priorities, and in democracies, we vote for these people. So they are part of the system and the context in which we are delivering health and well-being. Air quality, global heating, conflict, and a whole host of other things impact on the delivery of healthcare, but also on health and well-being itself. So we don't deliver healthcare in an unconnected way. If we're thinking about building for the future and making healthcare better and embedding pandemic preparedness in health, we need to think about embedding it in all of these elements, in whether we can make social and political society more favourable, improve housing, education, climate, all of these things. We cannot just do it by tackling health alone in terms of healthcare delivery. And when I thought long and hard about what is the one thing that actually everything comes down to about the delivery of health, from me at the bedside asking one of the relatives of one of my patients who's profoundly unwell that I need to put them on a mechanical ventilator because they've got multi-organ failure, through to vaccination, to all kinds of aspects of the thing that we call health. Actually, trust is at the core of every single one of those relationships and conversations and things that we build. And I know that Scott talked about health earlier on and trust, and I wanted to revisit that theme. So what is trust and how has it been impaired and what do we need to build? And I think there's calls for both pessimism and optimism in this slide that comes from the Edelman Trust Index that I know you saw some data from earlier. Institutional leaders, certainly in the 2023 data set, suggest that some types of them are less trusted than they have been. So government leaders had a net decrease in the amount that they were trusted, and they're still very much untrusted. So are journalists, and so are CEOs of companies. However, people were more trusting, actually, of the people in their own local community, of their individual CEO that they know and work for, as opposed to CEOs in general, their co-workers, so the things that they come into contact with their community, But also, interestingly, scientists. There was a net increase of 1 point in trust of science between 2022 and 2023. And whilst there has been much said about scientists and loss of trust in science and leadership, actually, there's optimism too. It's not potentially quite as bad as maybe it's discussed. We're still not down there with journalists or government leaders as yet. But that's an average of how people feel about trust. There is a really clear divide along socioeconomic lines about how people trust organisations. And I think this is one of the things that we need to bridge going forwards for the future. So this slide shows what the kind of trust is across nations, the Global 27 included in this survey, for the top 25% of people with income in those settings and the bottom 25 in those. And you can see the average trust of organisations, so NGOs, governments, business and other sectors. If your income and your socioeconomic status is lower, you are less trusting of those organisations than if you are of more higher means. So we're not all living in one society in the way that we might think. So the approaches and the things that we need to think about to build trust are very, very different for different sections of our communities. Ipsos Mori also have looked at some data around trust and have done a similar kind of global approach to doing surveys as Edelman do. And actually, they've looked at what types of organisations people have trust in. And interestingly, out of the organisations they asked, pharmaceutical companies were at the top. Which I was surprised about in this data, because given a lot of what the social media and other discourse that happens in the public domain is that we can't trust drug companies. There's been a huge amount of it, particularly in the pandemic. However, actually, they were the top rated above tech companies, food and drink, retail, all of the others. They were the most trusted. However, across nations, it's not stable. And you will see that some areas of the world, like China and India, have got much greater trust in pharmaceutical industry than perhaps places like France and the UK. So again, we are not all thinking about trust and understanding trust in a unified way across the globe. How we view our communities and our relationships are impacted by the ecosystem in which we live, by our political and social climate. So the solutions that we come up with are going to have to be bespoke for the communities in which we're trying to target. So how do we build trust? And this is so hard. But I think, again, there's some data that could help us. The Ipsos Mori poll asked people, of the 2 or 3 attributes, tell us what it is that makes you want to trust organisations. And the number one thing is, if people say what they say they're going to do, they do. So do they keep their promises? Are they reliable? And we'll come back to that. They value transparency and openness. They behave responsibly, and they provide good value for money. It's actually only the 4th ranked. People care a lot more about transparency and whether we deliver when we say we're going to when thinking about organisations. So I think some of the things that we need to build and we need to develop are data-based, in that we know what people think about when they think about whether something is trusting or not. But I think what it all boils down to is this. Trust is built with our actions, not our words. And this is where, particularly in the COVID pandemic, but also in historic pandemics before that, trust has been broken where people's actions and organisations' actions have not aligned with their words or their purported values. And I think that until we actually can address this and try and have organisations showing leadership whose actions and values align with the things they say, we're going to struggle. But what should we be aiming at when we're building trust? And I wanted to highlight this because there's been a lot of talk about equality and equity and liberation. And I think for me, this particular image shows exactly what we should be aiming at. Equality is not enough. If we give everybody the same thing, so everybody has access to a vaccine, that is not good enough, because what is needed by the individual societies and the individual communities which we are trying to help either prevent, diagnose and treat their health issues or get this state of overall well-being, depending on which approach we take philosophically from the beginning, they need different solutions. So what is needed in the UK is very different to what is needed in China, to what's very different to what's needed in Uganda. But better than all of that, we need to be working to remove the barriers, not just provide people with stepping stools on which they can stand to overcome them. We need to be trying to take away the barriers that people face. We've talked a lot about vaccines, particularly over the last couple of days, and I wanted to highlight another issue that actually has been more long-standing, perhaps, than around the issues we've had with COVID vaccines, and it's about a really simple therapy, so oxygen. Oxygen has been on the WHO's list of priority medicines for more than a decade at the start of the pandemic. For decades and decades, children under 5, and particularly women, actually have died from lack of oxygen every single year. And yet, very little action has happened about oxygen. We haven't treated it in the same way as we have perhaps treated other therapies or even thought about it. But oxygen became a particular pinch point during the pandemic for all societies. And to highlight that, I've taken some press clippings about oxygen across all sorts of health settings to explain that trust was broken because of the failure for us to be able to deliver this really simple thing to people that didn't think they'd ever have to worry about it. So, for example, in New York, the top headline saying some hospitals are facing an oxygen shortage amid a coronavirus crisis. Hospitals in New York had oxygen shortages that meant there wasn't enough for all the patients that they had. The same thing happened in the UK. A Hertfordshire hospital had to have its intensive care unit evacuated on a Saturday afternoon because the oxygen stopped coming out of the wall because they had so many sick patients. The same thing happened in India. It was on the news very regularly, and this is a BBC clipping. People died every single day because they could not get the simple life-saving therapy of oxygen. They weren't anywhere near having tocilizumab or dexamethasone or a whole host of other therapies. They didn't have oxygen. And actually, the WHO highlighted that actually more than 500,000 people and low and middle incomes every day were struggling with lack of oxygen. Now, there was more strain on the system because of the pandemic and the greater incidence of people requiring oxygen, but this is not a new problem. This is a problem that we have failed to address for many, many decades. And to illustrate some of this, some data from some collaborators that I've worked with. So we had looked at people who presented to Malago Hospital in Uganda in November 2015 to 2017, and we looked at all adults who were admitted to the medical emergency department who had oxygen saturations of less than 92% and said that they were acutely short of breath. So they had shortness of breath for the last week and no longer than that. Everybody got standard oxygen therapy, which was they got up to 4 litres of oxygen to keep oxygen a minute, to keep their sats above 92 if you possibly could. And we followed up the people and said, what happened to this cohort of people? Because there was no data on emergency acute hypoxic respiratory failure in this setting. Well, we screened 7,300 people, and 328 of them were admitted to hospital. The median age of these people was 38. Their saturations on admission, the median saturation was 77%. 77% of them died in hospital, and 85% of them were dead within 90 days. Now, there are very few health settings in the world in which 85% of 38-year-olds dying within 90 days is acceptable. 82% of them were thought to have pneumonia. And actually, interestingly, only 30% of them had HIV and less than half of them had TB. Most of these people were young people dying of community-acquired pneumonia, an entirely preventable disease, and with supportive care that could make it better. This is not a new thing. We have failed to address it before the pandemic, let alone in the pandemic. We were quite shocked about this single centre data. We're like, well, maybe this is something about Malago. Maybe we should have a look and see And so we started actually having planned in 2019 to do a study across Uganda. We also hit the pandemic period, but still managed to actually do a study where we looked at 39,000 people who were presenting to hospitals across Uganda. And again, they were presenting with acute shortness of breath, and saturations of 92% or lower, and were thought to be acutely unwell, not due to trauma. So we had a cohort of about 800 of people, and essentially what we found was that the median age of these people in the bigger cohort was 50. Their saturations were a little bit better at 88, and we wonder whether people were presenting slightly earlier in the pandemic because people were more aware of COVID. They were aware that they might need healthcare, and there was different infrastructure in place to when we'd done the original work. The 28-day mortality, however, was still 37.9%. So this is 50-year-olds. 15% of them received high-flow nasal oxygen or non-invasive ventilation or invasive mechanical ventilation at any point. But 20% of them never received any oxygen therapy at all. So this is 20% of people whose oxygen saturations were less than 92% due to acute illness at the time they presented. 1 in 5 of them didn't get access to oxygen therapy. Lung infection was the most common cause. And as you can see, that was their probability of survival over the days. So people died pretty rapidly, so in the first 10 to 14 days, and then it plateaued off. We were unable to do the 90-day follow-up in quite the disseminated cohort that we'd done before in the middle of the pandemic, so we only managed out to 28 days. In September 2022, there was a Lancet Global Health Commission on medical oxygen security launched. And there's been a lot of talk about oxygen and how we need to make it better. And actually, there was adoption of the medical oxygen resolution in May 2023. And so there's been lots of words spoken about oxygen security and making sure that this essential medicine is available to everybody going forwards. But we haven't delivered the action yet, and we need to make sure that our actions align with our words. So how do we embed lessons learned in the everyday work of healthcare? And had a few thoughts about how we might do that. I think we need to turn up. And by turn up, I mean there is a global issue around healthcare workers of all types actually leaving the professions and the roles in which they work. But we also need to turn up at a societal and a public health level too. If we do not commit to doing the work that's required outside pandemics and only turn up when there's a problem, we do not build the trust that is needed. We have to stand alongside and work with and support communities between pandemics every single day. It is hard work, but trust is only built over time. And I know as an intensive care physician that building trust in an emergency is not the time to be doing it. Trust in systems and that people are going to help them needs to be built over time. We need to acknowledge that health is multidimensional and is impacted by our surrounding ecosystem. So by the politics and the housing and the global heating and the other things that we are exposed to every single day. And we need to build trust by our actions. And I think I've made that point already. We need to focus on equity and removing barriers, which can be termed liberation. And we need to get the basics right. I think it's very hard to ask people to trust us when they have been saying, my child has been dying of oxygen, or my wife didn't have access to oxygen so that she could have surgery to have our baby, or even able to have an anaesthetic in the first place because there is no oxygen available. And then say, but you need to trust us to take this other thing that we've developed and we really want you to have, when their everyday experience is not that we don't have access to the basics and we don't appear to care about it. And we need to be honest about uncertainties and commit to learning what does and does not work. And this is really hard anytime, but particularly in pandemics. I think healthcare professionals and politicians throughout the strain of the pandemic, were not always honest about uncertainty. And we didn't all do everything we could to commit to learning what does and does not work. And by that, for me, it means embedding research and finding out what does and doesn't work as a strategy, whether that's about health communication or about vaccines or about clinical trials for therapies. We need to build the infrastructure that says we don't know now, but we could.